So what I'm going to primarily do in my talk to you today is discuss sleep apnea management from a physician's perspective. This is something you may have heard before, may not have heard before, but hopefully some of the videos will be interesting and educational to you, and you can see what exactly happens once a patient makes it to a surgeon's office. Before we do that, though, I want to give you a bit of a talk about OSA in the context of society. Now, some of these slides or concepts you may have heard before in our wonderful two presentations already from today, but I think repetition is probably very important, actually, because these concepts are critical so that we understand better the whole disease process. When we talk about sleep itself, there are two basic processes that are happening throughout the day to our patients. We call them process H and process C. So process H is homeostasis, and that's where this concept of the sleep load, or the need for sleep, builds up throughout the day until it peaks at about 9 p.m. or about 5 p.m. in my case, because I get tired very early, and you feel this huge need to go to bed and close your eyes. That's the homeostatic process, and it's mimicked and mirrored by the circadian rhythm, process C. That's another type of alerting signal whereby that keeps you awake throughout the day. It peaks a bit towards the, just before the 9 p.m. time, that starts fading off very rapidly. So in other words, as your process H maximizes, your process C is starting to decrease too, as your alerting signals go away. You feel the pressure to sleep. The longer you force yourself to be awake, the higher and higher the process H will come, and the less and less alerting signals will have. And so the sleep burden becomes immense, and eventually you can't help yourself and you fall asleep. A normal, typical, healthy sleep cycle for a regular person without sleep apnea goes through multiple cycles throughout the evening. They'll range from anywhere from mild sleep here, going to deeper early stage deep sleep, down to REM sleep down below, then a few cycles between stage 3 and stage 4 sleep, and eventually wake up at 5:30 in the morning, or sooner if you have children. But the point here is that this cycling happens quite naturally, whereas in patients with apnea, that cycle is completely disrupted. Instead of seeing a nice series of U-shaped curves going up and down, their cycle will look like this, all throughout the night, extremely fragmented, and never quite getting down to deep sleep. So these patients will have very fragmented sleep, and they will be exhausted throughout the day. I know you all know what sleep apnea is, but I'm going to go over it in detail anyway, because it's going to be a bit more from a surgical perspective. Sleep apnea is a disorder of breathing while sleeping due to collapse of pharyngeal soft tissue that causes intermittent airway obstruction. Once this happens, we have increased carbon dioxide in the body, decreased oxygen, multiple episodes per night, just like our previous talk spoke about. Here's pictorially what happens. We have a sagittal view of a patient here with the nasal airflow being blocked where the soft palate is touching the posterior pharyngeal wall. And we have oral cavity airflow blocked where the retrolingual obstruction occurs. These patients in a normal awake breathing state have an endoscopic view here, looking with an endoscope at the back of the nose. We're looking down into the throat, and so we can see the epiglottis, the laryngeal apparatus, and this is the back of the tongue. Here's this lateral and posterior pharyngeal wall. So this patient is quietly breathing while awake. And as they start to have their airway collapse down, the airway goes down to a little pinpoint, and eventually it blocks off altogether, and they can't breathe anymore, and that becomes the apnea. The pathophysiology of apnea has been discussed already today, so I won't belabor this point. Essentially, we have a situation where a patient is sleeping, then they get retroclavial, retrolingual obstruction, the airway blocks off, they get the obstructive apnea, they become hypoxic and hypercapnic, too little oxygen, too much carbon dioxide. This causes a physiological arousal, not necessarily a total arousal where you wake up and you say, well, I'm awake now, and you want to sleep, but it's a cortical arousal, and that the brain is not getting the rest it needs. It doesn't get that deep layer of sleep. You don't get rested throughout the day, and then you go back to sleep again. And the cycle repeats itself over and over and over, many times per night. Why do we study sleep apnea? Why bother? Is it that important a disease? And the answer, of course, as we all know, yes, it is. It's an extremely prevalent condition. About 3% of men and 9% of women at least have some mild sleep apnea, probably even moderate to severe. The overall incidence is rising as obesity increases as well. There are significant morbid health effects. These patients have all kinds of problems that we alluded to already today, ranging from headaches, somnolence, irritability. They have significant cardiovascular and neurological dysfunction. And these patients in general have an increased risk of death from any and all causes. There are also significant societal health effects. It's well known that apneic patients are in a large proportion of motor vehicle accidents. People who are apneic or chronically fatigued don't work well. They're not going to be as good as they can be at the desk, at their job, at whatever they might be doing. They won't be as good as they would be if they were well rested. And then consequently to society at large, there's decreased economic productivity. We are in the middle of a recession right now. We can't blame that on sleep apnea, but it's going to be partially contributing to it at least. Most importantly though, sleep apnea is a treatable disease. We can make people better. We can decrease their morbidity. We can decrease the societal impacts as well. So it's definitely a worthwhile disease to study. What are the consequences of OSA? They range from subjective complaints such as snoring and sleepiness. Those are the symptoms. But there are other more important signs that patients often don't complain about. They have neuropsychological sequelae, metabolic derangements, cardiovascular disease, the other things we discussed earlier.